Today's webinar, sponsored by MDaudit, is called Actionable Insights for Healthcare Billing Compliance Teams in 2025. Our intention today, before we get into anything, is to send the hardworking billing compliance folks, auditors, analysts, with some nuggets that you'll be able to bring back home to your programs to operationalize and see really good outcomes. First place we want to start here is just want to introduce myself. My name is Dana Finnegan. I'm the Director of Market Strategy at MDaudit. Really happy to be with you today. We're also going to just go through some really quick housekeeping items that usually come up as questions, which one is you will be receiving this deck after the webinar. You'll also be receiving the recording post-webinar. You will be asked to take a survey at some point during the webinar. It's just to hear about future topics you may want to hear about, a couple of other questions, so please feel free to take part in that if you'd like. We are also going to be talking about a lot today about the MDaudit 2024 benchmarking report. You will also be able to receive a copy of that when you receive the deck. You can scan a QR code or come to our website. And the last thing I would say is just if you have any questions, please enter them in the chat. We may not have time for questions at the end. It's only a 30-minute session, but please enter them. So just a little bit before we get into the insights, a little bit about MDaudit, who is sponsoring this. MDaudit is a billing compliance, a leading premier billing compliance and revenue integrity platform. 150 clients across the country. All sizes and constitution. The reason why we're bringing up MDaudit is because all of the insights we're going to bring you today are from the MDaudit 2024 benchmarking report. So you can see just really quickly, we have over 30 years of experience in revenue cycle, revenue integrity, and billing compliance. The platform is used to audit over 650,000 providers and 75,000 coders. A lot of AI and analytics that are looking at root cause of why providers are failing audits, why coders may be failing audits, root causes of denials, all of those things within our community. We want to expose a lot of what we're finding within this massive community to you, so you can say, am I having similar patterns? Are these things these are the things I should be looking into when I go back to my billing compliance and revenue integrity program. One last thing I would mention about these insights is this is not a survey. This is us looking into our database of just millions of claims, millions of remits, and doing a lot of work on that to bring these insights directly to you from our very robust MDaudit community. So we wanted to really spend some time on things that directly affect the billing compliance folks, you folks. So we want to provide some insights. And I think the first one that we saw was that through the use of analytics and technology, and we'll talk about what that means, we've seen a really big increase in 2024 over 2023. You can see there was a 35% increase in the number of just audits that were done by auditors and analysts, both on the professional billing side and the hospital billing side. And the really great thing about that is that 35% increase in the number of audits that were being done were with the same teams, where there was no increase in the team or even slight decreases to the billing compliance team. So even with the low amount of FTEs on those billing compliance teams being asked to do so much, they were still able to increase their productivity. And really, the thought is, how did that happen? Well, it happened by those teams implementing technology, helping them use AI and analytics and benchmarking to really interrogate their claims volumes and denial volumes and point them in the right direction to say, here are your overcoding physicians, here are your undercoding physicians, here are your coders with the lowest levels of accuracy and integrity, all by running their claims data and denial data through algorithms and analytics and AI to pinpoint those at-risk provider trends, coder trends, and billing patterns. So there is technology out there that can do that. When I talk about benchmarking, I talk about how do your providers compare to what CMS considers normal billing patterns by specialties. We also were able to take and look at all of the different providers that were being audited on our MDaudit platform and created our own benchmark, the MDaudit community benchmark. And we're able to really, again, point folks in the right direction by specialty, by code, by CPT, by DRG, where the highest risk cases were. So just remember, if you're working in a very manual environment, with no analytics, no AI, no trending and benchmarking, and you're still doing your provider and coder audits on spreadsheets, that could put you at some risk of missing things. Automation, pulling sample sizes for you, running analytics and benchmarking, that can all put you in the driver's seat so you can spend more time understanding risky billing patterns that'll affect the financial picture of your organization, and leave you more time for education. So again, what we want you to take away is no more should you be relying just on spreadsheets, requesting data from IT, bell curves from IT. You got to have a platform that can support you. So you will see a similar increase, even if your teams are staying the same or losing folks for whatever reason that may be. We'll talk more about that technology as well. I think another one that is a really big one here is you can see on the left-hand side in the MDaudit community in 2024, retrospective audits increased by 10%. But the bigger number there is on the right. Prospective audits increased 275%. That is just a massive increase. What does that tell us? That tells us that, one, you really, in billing compliance, have to be employing a blended strategy. You should be doing both retrospective audits and prospective audits. Those prospective audits can be done for your physicians, for your coders, high-risk billing patterns. But again, you want to take that blended approach. When we see folks going on that prospective side of things, even though it's holding up some claim volume, and it may, cash flows may be take a little bit longer with that prospective approach. Don't be afraid to do it, because what we're seeing is massive increases in first pass pay rates, less denial rates, cleaner claims, and at the end of the day, cash that will come through the door without having to spend massive amounts of resources appealing claims. So again, I think the takeaway is make sure that you're employing a blended approach. And I'll say this, 5-6 years ago, we saw the prospective audit starting to creep into the billing compliance community. Now that's the norm. So not only should you have a blended approach, but you should be moving, if you can, to the right side there, where you're doing more prospective audits than you're doing retrospective. And again, there's technology out there like MDaudit that can really help you, hold those charges the appropriate amount of time, allow you to do those prospective billing compliance audits, have that appropriate dialogue with your coders, pre-bill, so when you are sending those out, they are getting paid on that first pass. So let's go on to our next thing that we were seeing within the MDaudit community. This one's a really big one. We saw a 72% increase in risk adjustment and HCC audits as well. And the reason why is, there's been a ton of noise out there, particularly with Medicare Advantage plans, that these HCCs are being highly scrutinized. So if you're sending out HCCs, if you're in a value-based care model, a value-based reimbursement model, these are being heavily scrutinized by the government, particularly by commercial payers, and that's why you're seeing that 72% increase. We have heard that that the OIG is reporting that almost $50 billion in overpayments were related to these HCCs. So what that means is you're going to continue to see clawbacks and takebacks of these. So if we think about it, what we've seen in those last 3 insights is team amount of FTEs there. And the second one there was, again, we'll go back to that, was that there's an increase in prospective audits. What you can do now is think about it. Start putting some of these HCCs on a prospective audit process, because these ones, again, are being your entire payer mix. And we're even see some of these resulting in systemic fraud and abuse. We're not saying anybody's out there to fraud or abuse, but it's out there. It's every time you see a publication by maybe Becker's or others, these are being highly scrutinized. So if you are able to employ a risk-based approach, if you are able to employ a prospective approach through technology and automation, put this at the top of your list, your HCCs, particularly when they're being billed to Medicare Advantage plans. Here's where I think the MD audit, when I looked at the data within the MD audit community, was kind of a really interesting. So more than 25% of providers on average failed audits on both the pro fee and facility side of the world. Now, I know some of you are saying on the facility side of the world, inpatient and outpatient, coders are coding a lot of those services, and that's true, but the provider also needs to have excellent documentation. So, but we wanted to say that you should be able to very easily audit your providers and coders, meaning, and I'm going to go back to it again, you shouldn't have to be requesting data from IT. You shouldn't be waiting for that data. You should be able to just basically say, hit an easy button through automation and technology and say, give me a sample size of 10 claims, 10 charts, 10 claims for this specialty or for this coder group, and immediately have that at your fingertips. And when you're able to do that and have that automation, you're going to be able to get through your entire provider population. If you're taking a risk-based approach that's just saying you've got 1,000 providers, but here are the 20% that are causing the overcoding and undercoding through risk-based approach and benchmarking, when you see those providers too, you're going to be able to immediately vet out the ones that are failing, that don't have the highest level of accuracy and integrity. So really what we're saying here is if you're auditing your physicians and getting through your physician population, you're going to see there's still a large percentage of providers that are failing on both the pro fee and facility side of things. We're going to talk about coder audits as well. We're even going to show you some of the common reasons coders are failing. But let's get into some of the reasons for provider failures. And one thing I should mention at this point in the session is you're going to be able to get access to the MD audit report, benchmarking report, that's going to show you not only the stats you're seeing now, but the codes that they were failing at, the diagnoses that they were struggling with, the CPTs, the DRGs. You'll get all of the backup. And my hope is you'll read this report and then take some of those insights and bring that to your program. Start auditing those CPTs, start auditing those DRGs and diagnoses that the MD audit community is seeing at risk. But on the pro fee side, let's look at some of the failure reasons. So diagnosis documented but not billed. Now, someone's going to say, we're all going to think, well, the physician appropriately documented the diagnosis. What that one means, it's in a whopping 58%, was the diagnosis was documented, but it didn't have as much robust documentation as needed and was warranted to build to a higher level of specificity, which would result into more reimbursement. So again, we always want to be looking at those diagnoses that are documented and seeing, is there opportunity there? And if there is, educating physicians and saying, if you had just added certain verbiage, this is the result. The other ones weren't as kind of big as the 58%, but you can see here, modifiers were not being appended. E&M services overcoded one level. E&M services undercoded one level. And again, we're going to give you all of the backup of the CPTs and the diagnoses causing these failures. Diagnoses not linked correctly. So that's kind of on the pro fee side. On the facility side, a lot of it really around primary and secondary diagnoses. So really, if you're not doing prospective audits or even a blend of retrospective and prospective audits of your coders and physicians that may be appending or documenting some of those primary and secondary diagnoses, you really want to start taking a look at those. So again, you'll get the backup to this, but just wanted to show you some of those failure reasons. I think the other thing that we want to talk about is what we've mentioned so far up to this point was what was going out on claims. Auditors auditing what was going out on claims. Right now, we want to talk a little bit about denials. And one thing I would say is in the last year to 2 years, we've seen the billing compliance constituency becoming much, much more involved with denial population in what falls under their purview. Things like medical necessity and payer deems the information submitted doesn't meet this level of service. Things like that. These are ones that fall under the billing compliance purview. So if you're just looking at claims and you're not diving into root cause of denial, that is a huge gap. So please, please, please reach out to us, reach out to someone that can help you really consume and find the root cause of your systemic denials. That's something automation and technology can certainly help with. But I think the biggest takeaway from this is you all can see here in the middle that the increase on the inpatient side was largely driven. It was 30%, over 30%. We saw average denied amount per claim in the MD audit community going up 30% on the inpatient side, particularly driven by Medicare Part A. On the commercial side, which is going to be all the different commercial insurances, it went up 30% on the pro fee side. So really what we saw when we broke that down was Medicare Part A denials were much around outlier lengths of stay, really long lengths of stay were being denied for med necessity and other reasons, where there was a lot of CCs and MCCs involved. So I implore you, I'm asking you, go back and do some audits, prospective, retrospective, your inpatient, long inpatient stays with CCs and MCCs. You're going to see a similar pattern. The other thing I would say is on the pro fee side, that was largely being driven by office and emergency department visits. So you really want to, for your commercial payers, go in there and see the ED E&Ms that they're denying, the ED codes and in the office codes as well, because huge amount of denials per claim increasing. And you don't want someone coming to your desk and saying, why weren't you aware of this? These are things that fall under your purview. So again, please take a look at your denials as well, particularly in those areas. I think the other thing that we were really shocked by, and it was nothing that was, anyone in the MD audit community could really control, but when we talk about denials, the ones for information needed and medical necessity really went through the roof. So you can see here on the right-hand side, we'll stick here, that the increase from 2024, from 2023 to 2024 in the MD audit community, Medicare Part A, RFI denials, requests for information, went up 56% with Medicare Part A. Commercial insurance is 122% in just 1 year. So what does this mean? This means you could be reviewing what went out on those claims and say, these are absolutely meeting the highest level of accuracy and integrity. And that's your job. And that's the coder's job, obviously, making sure those are going out to the highest level of accuracy and integrity. But what we're finding is these payers are saying, yeah, great, you did that. But a lot of the claims that are being billed out need attachments. They need supporting documentation. I'm going to give you an example that we saw in the MD audit community. We had folks that were billing from one of our very large organizations, leadless pacemakers, when the pacemaker manufacturer was Medtronic. Everything on those claims was absolutely coded to the highest level of accuracy and integrity. But what was missing was the actual device number of that pacemaker. That one little loop and segment on the claim caused a loss of millions of dollars. So we're not saying that as a billing compliance person, you're going to know every payer policy. But what we're trying to get across here is continue your jobs, making sure things are going out appropriately, but become very familiar with payer policy. Meaning, when you start getting denials for med necessity, information needed, documentation needed, don't kind of stop there. Drill down a little bit, find out why that's happening. Get to the CPT code that's being billed, the procedural code that's being billed. In this case, the pacemaker, and go in and I know it's hard, but go in and look at that documentation and say, okay, when I'm billing out this code to this payer, they are expecting this. It's in the documentation. It's in the clinical policy. Again, we talk about technology. Technology can consume your payer policies and put them in front of you to let you know things like what's going to deny, why it's going to deny, and how to fix it. You can't even look at this on a preemptive basis. There are technologies out there like MDaudit that can say, look, this is going to deny at this payer unless you put this clinical trial number on it, or this pacemaker manufacturer number on it, or you need to apply this type of 3 bullet points as to why you're not going with this therapy, but you're going with another therapy. That can be provided through automation and technology. But what I'd want you to take away from this, folks, is you want to start looking at your denials specifically for information needed in med necessity. I can guarantee you're going to see a huge spike in those, and you're going to want to drill in and figure out why. The last thing we kind of want to get into is going to be absolutely related to you. You're going to be, a lot of you are auditing coders. You're having healthy dialogue with them. Hopefully, you're doing reviews and rebuttals with them. You're talking every day. Again, technology, I won't go into the deep dive of it. Technology can very easily allow you to audit coders. Technology can match up the claims with who coded them. So that coder can do a review and a rebuttal, and you guys can have that dialogue even before the claim goes out the door. And the reason why I'm really pressing on you folks maybe thinking about technology that can do that is because look at this, coding related denials in the MDaudit community increased by more than 100% in 2024. And you can see, particularly on the inpatient side, that went up 219% for average denied dollars, just through the roof. Now, the reason why I'm kind of most concerned about this is because there's a lot of buzz out there about, first of all, we see a lot of organizations outside the MDaudit community that are outsourcing their coding operations. If you're outsourcing your coding operations, it may be a necessary evil, but you're not able to really dive in and see what's going right, what's going wrong. It's kind of outsourced. It's out of your control. And that's not necessarily a good thing. The other thing is there's a lot of reliability now on autonomous coding technology. We're not maligning that technology, but it's not fully baked yet. There's a lot of mistakes being made if you're just relying on autonomous coding and you're not heavily QAing it, or there's not governance around it. So with outsourcing being done and autonomous coding, this is directly relating to more coding related denials. So again, we're all for technology. We're a technology company, but there always has to be people in the loop. If you're outsourcing it or you're using autonomous coding, you still have to have auditors and coders in the loop, constantly reviewing this to make sure that what's being sent out is appropriate. And you also want to be employing, you want to try to bring those audits back in-house. And when you're just auditing coders, you have to make sure that there's enough time to be meeting with them for education and root cause. So again, you're going to say to yourself, well, I don't have enough time. But if you automate a lot of those processes, the sample pulling, a lot of the benchmarking that could point out accurate coders, not so accurate coders, you will absolutely have time to bake in that educational piece and have that healthy dialogue with coders and physicians on the professional side to make sure that the coding related denials are mitigated. But I bet you, and we want you to go back in and look at your denials, and you're absolutely going to see that coding has gone through the roof, particularly on the inpatient side. And again, you will get this report and you'll be able to see the very specific codes, CPTs, DRGs, all of that make up these very staggering numbers. Here's another piece that we want to talk about. So this is, I've actually given some of the backup to this, but another staggering statistic was more than 50% of coders were failing audits across the prophy and facility settings. So, I mean, it was 25% over 25% for physicians, more than 50% for coders. And when you think about it, that's scary too, because coders are coding the really high dollar inpatient lengths of stays, CCs, MCCs, HCCs, where there's a lot of reimbursement at stake. There's a lot of cost associated with those patients. So again, might seem like a no-brainer, but you got to be auditing your coders. You've got to be you got to have them doing reviews and rebuttals. This has to happen fairly real time. And you have to be able to be talking together until there's resolution to ensure what's going out on those claims is appropriate. And that both of you, auditor and coder, are familiar with payer policy, because as we talked about, it can be accurate and perfect, but you need to know the documentation the payers are looking for and things like that that'll help you meet that medical necessity hurdle. But if you look at pro fee, the highest dollar amount, again, is payer deems this information does not support this level of service on the pro fee side. On the hospital outpatient side, same, the biggest amount there is same thing, $849. Payer deems information submitted does not support this level of service. And on the hospital inpatient side, $5,000. Also, payer deems information submitted does not support this level of service. What's the payer telling us here? In all three cases, they're saying you are overcoding. So I think what you want to do here is that this is going to continue as you need in all three chart types, pro fee, hospital inpatient, and outpatient. You need a technology that with an easy button can drill you down to the codes, whether it's the diagnosis, CPT, DRGs, whatever it is that the payer is saying doesn't support the level of service. And at that point, you need to go back and have those conversations with your coders and saying, this is why you're not meeting the highest level of accuracy and integrity to meet what they consider the appropriate level of service. Now, there's going to be a lot of times that the payer you're going to want to fight that, but you're going to need to know what payer is denying me for this. What is the code? You can't have that deer in the headlights look when you see these and not know where to go. Again, technology can help you drill down to the payer, the code, the physician that's having the issue, even the coder that's coding those services. So if it truly isn't meeting that level of service expected by the payer, you can educate the physician or coder because you know who they are. And if you feel you can fight it, then you've got the information at your fingertips to go in and fight those denials because you're able to identify the account numbers that those denials are linking back to. So again, don't try to do your job without technology. Technology can really help. The other thing I would say here on the inpatient side, as we talked about this before, primary and secondary diagnoses on your inpatient long lengths of stay, please be auditing primary and secondary diagnoses along with your DRGs and POAs and things like that. They are a huge killer. You can see here, diagnoses are not covered. $49,000 average denied amount. It's just whopping. So again, understand your claims volume, understand your denials volume, have that dialogue with your coders and your physicians, and you'll do great. The last thing I would say here before we let you go, and I know we're against time, but payer audits. You may be doing great with your denials and your billing compliance, but the amount of letters coming from RACs, MACs, and commercials just went through the roof. In 2023, the at-risk dollars for clawback from these external payer audits was 2.6 million. Last year, 2024, or this year, 11.2 million. You need to understand that these letters, these ADRs are going to continue to show up at your back door, and you're going to need automation and technology to help you fight that good fight, help you get those medical records back within a couple of days, help you understand the determination, tag your claims with what has happened, and help you fight those appeals. So just understand that you need to have support when it comes to managing those letters. Many folks are forfeiting the right to retain that hard-earned revenue because you're not able to get the records back to them. You're not able to get the appeals documentation back to them. These letters are just sitting somewhere on a desk and they're lost. Automation and technology can put you in the driver's seat to retain a lot more of that revenue. One quick statistic, in the last 12 months, customers in the MDaudit community using our technology retain more than $100 million in at-risk revenue through automation. So at the end of the day, there's a lot of denials out there. There's a lot of billing compliance fights, but also make sure that you're able to fight and quickly respond to your external payer audits. Folks, the last thing I want to say is you'll be getting this deck. You can hit this QR code to get the full report. That'll show you everything we talked about, plus all of the backup that'll help you operationalize that into your billing compliance program. Thank you for taking a survey today. I can see it up on the screen now. Please let us know any other topics you may want to hear about. And again, we really hope you come and visit our website, get this report. I think you'll be able to do a lot with it. And just so you know, MDaudit in 2025 is going to start a new series of webinars based on what the OIG is scrutinizing, new items to the work plan. We're going to break those down, make them consumable for you, so you don't have to do as much work on your end trying to find out what's being added to their plan. So look forward to that series. Thank you very much for your time, folks. I'm going to let you finish taking the poll, and hopefully we will see you at our next webinar.